Bismillahirrahmanirrahim. Assalamu alaikum everybody. I hope you are okay and safe at home. Today the topic is thyroid disorder in children. You know that the thyroid disorder include hyperthyroidism, hypothyroidism and thyroid malignancies. Thyroid malignancies and hyperthyroidism are very rare in children. So hypothyroidism is common disorder in children, especially the congenital hypothyroidism. So we will discuss more on hypothyroidism in children. You know the thyroid hormones are thyroxine, that is called T4, and T3 triiodothyronine. So everything from brain to skin is affected by thyroid hormone. There is hypothalamic pituitary thyroid axis, which includes the thyroid gland, hypothalamus, and pituitary in the brain, and these are the hormones known as TRH and TSH. These hormones regulate the thyroid hormones. Now the embryology we will discuss a little bit. Synthesis and secretion begins in the 12 weeks. By 12 weeks of gestational age, TRH and TSH are detected by the end of first trimester. Till the 18 to 20 weeks, hypothalamic pituitary thyroid axis activity is low. Ability to adapt to exogenous iodine remains premature till 36 to 40 weeks of gestational age. This slide is very important to understand because when to do the thyroid screening, newborn screening. So actually the TSH, there is within the 30 to 60 minutes there is a early postnatal surge. Postnatal means after the birth, and there is rapid fall over 24 hours, and then falls to 10 units, that is normal borderline by 1 week. In this way the T3 T4 peaks 24 to 36 hours and gradually decline to 40 to 4 to 5 weeks. And in this preterm is similar pattern, but there is blunt response. So this slide is important in this way that we cannot do the neonatal screening on the day 1. So I will tell you what is the ideal time for doing the neonatal screening in the further slides. Now hypothyroidism may be is the most common thyroid disorder and may be congenital, may be acquired. You know the acquired causes of congenital hypothyroidism are usually mostly autoimmune disorders including the Hashimoto thyroiditis, and they present late. But the congenital hypothyroidism is the most important because it affects growth and development of both in the children, and the mental retardation is common cause of congenital hypothyroidism is a common cause of mental retardation in children. So congenital causes includes the ectopic means ectopic thyroid gland due to developmental anomaly in the embryology. Then there is agenesis is most common. 90% of cases are agenesis, means the formation of the thyroid gland is not proper, and then after the agenesis there is a defect in the synthesis of thyroid hormones. So this is known as dyshormonogenesis. It includes the following process. Number 1, iodine transport defect, it is congenital. Thyroid peroxidase defect and thyroglobulin synthesis defect, and the last is the deiodination defect. These are all causes the dysharmonogenesis and accounts for 10 to 15% of cases of congenital hypothyroidism. But the agenesis and ectopic is 90% of cases are due to agenesis and ectopic thyroid gland. Hypothyroidism, other causes may be TSH unresponsiveness, means the defect in the receptor level, and then there are maternal antibodies including thyrotropin receptor blocking antibody, which can cause the hypothyroidism in the neonates. Iodine deficiency, endemic goiter, it also is a major cause of goiter and the thyroid hypothyroidism in our country. Then the maternal intake of certain drugs in pregnancy affect the child and they present with early life with hypothyroidism. Other causes maybe they are rare: TRH deficiency, TSH deficiency, and sometimes idiopathic cause of hypothyroidism. Hypothyroidism is associated with some syndromes which are interesting. Number one is Pendred syndrome, which includes the hypothyroidism, goiter, and deafness, and it is due to mutation in the pendant gene. And second is the Bamford Lazarus syndrome. When you see the hypothyroidism with cleft palate and spiky hair, suspect this syndrome, and it is due to mutation in the TTF2 gene. Then you may heard about the ectodermal dysplasia. Ectodermal dysplasia, it is a condition in which there is absence of the perspiration or sweating, it and plus hypothyroidism and ciliary dyskinesia combinedly they can is associated in the ectodermal dysplasia. Other syndromes are also associated with hypothyroidism. You know that the Down syndrome, and Turner syndrome, they are, and some trisomy are also associated with hypothyroidism. Now, the congenital hypothyroidism may be transient, may be permanent. Transient causes are like antithyroid drugs taken by mother, iodide excess, iodine deficiency, transient hypothyroxemia of the prematurity. It means the premature babies are born, there is a transient hypothyroxemia. And their other cause may be TSH receptor blocking IgG antibodies, which cross the placenta and cause the transient hypothyroidism in children, in neonates. Now, the permanent is important. Permanent cause of congenital hypothyroidism is thyroid dysgenesis, as I already told, because of thyroid gland is not formed. So it is a commonest cause of hypothyroidism. Then the dysharmonogenesis. Previous slide I explained that there are four process mechanism by which the thyroid hormone is not synthesized due to congenital defect. Third is a TSH resistance. Resistance means at the receptor level. TSH is formed, but it is not active, so there is a resistance, TSH resistance. Last is the central hypothyroidism. Central means when there is cause is in the gland, thyroid gland, it is known as primary hypothyroidism. But when the cause is central, like hypothalamic or pituitary, as we see in pain hypopituitarism or hypopituitarism, in which more than one hormones are involved, and cause is in the upper story in the brain, it is known as central hypothyroidism. So we will discuss in the interpretation of lab investigation How will you differentiate between the central primary and central hypothyroidism? Now the presentation of congenital hypothyroidism. Before presentation of congenital hypothyroidism, uh, the acquired hypothyroidism present late, usually autoimmune due to autoimmune causes like Hashimoto thyroiditis, and in the acquired one they can present with short stature, delayed puberty, and obesity. But now first we are discussing the presentation of congenital hypothyroidism. So the most infants, 95%, are asymptomatic at birth, but they may be post mature, and weight and length are normal at the time of birth, and we can get the wide posterior fontanelle. You know that is and you are aware of anterior fontanelle, but there is the posterior fontanelle, it is wide and delayed closure. We must suspect the hypothyroidism. Prolonged jaundice. Prolonged jaundice is, as you know, that the physiological jaundice is common in the newborns, but if it is prolonged after a certain period like 10 to 15 days, then we must think of hypothyroidism, congenital hypothyroidism, because it can cause the prolonged jaundice. Then the sluggishness and somnolence. Children, newborns, they are lethargic and they are not active and sleep all the time. So this symptom may uh, alert us to consider the hypothyroidism. Then the poor appetite and feeding difficulties. This feeding difficulties are common, but at that time we cannot recognize, mother cannot recognize what is the problem. There is a feeding problem and the poor appetite and sluggishness. So this may be a case of congenital hypothyroidism. Then you know the umbilical hernia is common in hypothyroidism. Macroglacia. Macroglacia means the enlarged tongue. Tongue is large size and it is protruded outside the mouth. Then the mottled skin, constipation, creatine. Creatine means congenital hypothyroidism and mental retardation. And the protuberant abdomen. Abdomen is distended. The patient may have constipation, may have the umbilical hernia. So all these features may be present at the time after birth. Okay. Next. Presentation of congenital hypothyroidism 3 to 6 months. फर्स्ट थ्री मंथ्स में जो प्रीवियसली हमने डिस्कस किए हैं यू मे फाइंड, बट नेक्स्ट 3 to 6 मंथ्स एज में इफ़ अनट्रीटेड, अगर कोई बच्चा डिटेक्ट नहीं हुआ है, उसकी न्यूबॉर्न स्क्रीनिंग नहीं हुई है, किसी कंसल्टेंट से नहीं गया है, तो देन patient may present with the coarse facies, eyes are apart, there is a depressed major nasal bridge, and the palpebral fissure is narrow, and the eyelids are swollen, and the mouth is open with protruded tongue, as I said. So in the next you will see the picture. So coarse feature is the most important sign to recognize the detect the congenital hypothyroidism. You can appreciate while first look, and child may be stunted, short extremities, neck is short and thick, delayed dentition in the later on. Hands you may find broad and fingers are short, skin is dry and scaly and little perspiration. There is little or no perspiration, means sweating. So hairs are coarse and scalp is thickened. Hairs of scalp hair are thickened, and it is the skin is also thickened, and you may get the harshness of the voice. And later on, the last cause is developmental delay, delayed puberty, and short stature. These are the later signs, but unfortunately sometimes the congenital hypothyroidism is diagnosed late, even after 10 to 12 years, and we are running the endocrine OPD, and they are sometimes come with mental retardation, delayed puberty, and short stature, and the developmental delay. So, as I explained the last features, you can appreciate three pictures. In these three pictures, there is coarse facies. Facies are coarse. Tongue is outside the mouth. There is a macroglacia, and there is the eyelids are swollen, and there is eyebrows are apart. The hairs are thick, and you can appreciate. And if you look at the patient, you recognize in the first look. So all the features are present in these pictures: coarse facies, mouth open, protruded tongue, swollen eyelids, and the eyebrows apart and coarse facies. Then there are comorbid condition or association of other disorders with hypothyroidism. You know that the diabetes mellitus is an autoimmune disorder. So it with Hashimoto thyroiditis, 10% of Hashimoto thyroiditis can present with the diabetes, and we have patient in the endocrine OPD and endocrine department who has diabetes mellitus as well as the hypothyroidism. Then in the later age, uh, infertility, menstrual irregularity can present with hypothyroidism. Then the dyslipidemias. You will find high cholesterol and LDL in the hypothyroid patient, and sometimes heart is also affected. There is pericardial effusion. Patient may, if untreated, patient may go into congestive cardiac failure and sometimes coronary artery disease, and sometimes you may find the deteriorating renal functions, CKD. So I discussed earlier that universal screening, neonatal screening is important to detect the congenital hypothyroidism, because congenital hypothyroidism is preventable, is treatable cause of mental retardation. In the Western world, every baby is screened for neonatal screening for the hypothyroidism, but unfortunately in our country it is not yet started. NICH is starting neonatal screening, and the plan with the help of Sindh government, and it will start soon. Neonatal screening was started in the 1970s, and the ideal, this is the important to understand, and you should remember, ideal time is 3 to 4 days. In the previous slide I told, okay, there is surge of TSH and T4, so we cannot do the thyroid screening on the day one. Ideal is the day one, because there are normal deliveries, they are in the patient is a hospital, so you can day on the day one, but it is not reliable. So it is ideal time for doing the screening, newborn screening for thyroid is the 3 to 4 days. न्यूनल स्क्रीनिंग कब करनी चाहिए, व्हेन टू डू द न्यूनल स्क्रीनिंग? ऐसे तो आइडियली तो हर बच्चे का जो आफ्टर बर्थ, आफ्टर डिलीवरी न्यूनल स्क्रीनिंग होनी चाहिए ऑन 3 to 4 days. बट व्हेन देयर इज यू फाइंड द क्लिनिकल फीचर्स, there is a family history of hypothyroidism, thyroid disease or anti-thyroid drugs taken by mother, presence of other conditions like Down syndrome, as I already said, trisomy 2018, and neural tube defect. Neural tube defect means it includes the spina bifida, meningocele, meningomyelocele. So when you find such patients, the thyroid screening or thyroid test must be done. And any case of congenital heart disease, mental disorders, metabolic disorders, Pierre-Robin syndrome. You may heard of the Pierre-Robin syndrome. it is there is a micrognathia, chin is small, there is a cleft palate, and there is macroglycia as compared, because the as the chin is short, so it looks pseudo microglycia. So these are the syndromes which are associated with hypothyroidism. You must do the thyroid function test. And sometimes familial autoimmune disorders are in the families, run in the families. In this case, any child you come in the contact, must thyroid function test must be done.
Start to you.
Next. This is a rapid clinical scoring QBAC. It is known as QBAC. There are total 13 points, and out of 13, if you find 4, so you must investigate. Feeding problem 1, constipation 1, but the coarse facies has 3 points, and open fontanelle has 1.5, and the dry skin is 1.5. So you calculate, if it is 4 out of 13, then you score, then you must investigate for the hypothyroidism. Yeah. Scoring approaches, screening approaches, cord blood or heel prick on dried blood spot filter uh, paper at 3 to 4 days of life, and the primary TSH backup with T4 means you have to do the some screening. Ideally, TSH and free T4 or T4 should be done both, but it is costly, so you can do first the TSH and backup with T4 should be done. But this may be miss central hypothyroidism, because I said that the central hypothyroidism is secondary hypothyroidism, and this in which you will get TSH and T4 both low. ठीक है. So ideally for the diagnosis, TSH in the primary hypothyroidism, TSH is high and T4 is low. So thyroid binding globulin deficiency may be missed, and the hypothyroidism with elevation of TSH may be missed. Screening approach, primary, sometimes some countries do first the T4 and then they do the TSH, but this may miss the mild cases of mild elevated low, mild delayed low T4, and sometimes concomitant T4 and TSH. So ideally T4 and TSH both should be done. Free to T4 is advised in the preterm babies or sick babies, newborns, and immature liver function, undernutrition, and low level of the thyroid binding globulin or abnormal protein binding. Diagnosis of the hypothyroidism is easy. Newborn screening, sometimes if the newborn screening is already done and suspected, you should do both TSH and the T4 should be repeated. And then TSH, we expect in the primary hypothyroidism, T4 is low and the TSH is high. And to determine the etiology, sometimes we do the radio nuclide scan or thyroid scan or ultrasound to detect whether there is there is ectopic thyroid or thyroid agenesis. So the thyroid scan and ultrasound will tell the thyroid gland is present or not, or it is ectopic, or it is hypoplastic or agenesis. And then thyroglobulin should be done to determine the thyroglobulin deficiency, and the maternal anti-thyroid antibodies should be done if there is any history of hypothyroidism in mothers. And sometimes we need to do the urine iodine, but sometimes MRI brain and eye examination for optic nerve hypoplasia associated with hypothyroidism is needed, but not usually. Diagnosis, as I already said, the TSH is primary test. Additional tests are free T4, T3, T4, and but usually we don't need T3 in the hypothyroidism. In the hyperthyroidism, you should do all three: TSH, T4, T3, and T4. But in hypothyroidism, you do only the free T4 and TSH. And thyroid auto antibodies are indicated in the autoimmune disorder like Hashimoto thyroiditis. And thyroid scan or ultrasound, as I already said, to detect whether there is ectopic thyroid or thyroid agenesis. For that, ultrasonography and the thyroid scan is important. Sometimes children with hypothyroidism present with goiter, then we have to do the ultrasound to know the how many lobes are involved, and the in the cholesterol level is always high in hypothyroidism. Serum TSH level, as I already said, that the in the primary hypothyroidism, TSH is increased, and if it we get the more than 50 units, it is usually permanent congenital hypothyroidism, because and T4 is low. T4 is low and TSH is highly raised. It in the newborn, the new early life, you must label as permanent congenital hypothyroidism. Low T4 and normal TSH we can get in congenital complete or partial thyroid binding TBG deficiency. If we find serum T4, T4, free T4, TSH abnormal, then abnormal, not normal. Abnormal means we should start the treatment. And thyroid scan, ectopic are absent, start the treatment. Other test for etiology, decision in the borderline cases. Sometimes we can get the levels borderline. Then we have to repeat the both test to differentiate between the transient and permanent hypothyroidism, and sometimes familiar form, and the for counseling purpose we have to look for etiology. Otherwise, the treatment is the same in all the cases. All the cases may be ectopic, may be agenesis, may be dysharmonogenesis. The treatment is same, but sometimes for the counseling purpose, we do other test. Regarding the antenatal diagnosis, it is fetal goiter increase the amniotic fluid and the bradycardia. So the genetic testing can be done in the fetal cells in the amniotic fluid. Otherwise, it is difficult to diagnose antenatally. Fetal complication due to maternal hypothyroidism, the chances of prematurity, low birth weight, fetal distress, and sometimes intrauterine death and congenital hypothyroidism is always present. Transient, the treatment goals. Goals means it may mimic the normal levels, hormone levels, and alleviate the symptoms. And the hypothyroidism, apart from the clinical features, may present with bradycardia, may present with heart failure, maybe may constipation. As you know, these are the symptoms which are with passage of time with treatment, these symptoms go away, and signs also go away, and but it is individualized depending upon the compliance of the treatment. Thyroxine is indicated in hypothyroidism. As I said, that the pituitary TSH suppression in the central hypothyroidism, autoimmune thyroiditis, and it may use as a adjunct therapy to surgery, and the iodine in the management of the thyroid cancer, thyroxine can be used. Now the dose is in children is a 10 to 15 microgram per kg per day initially in the newborn period, and if dose is missed, double the dose next week. Okay, it is a OD dose, one dose. It is given in the before the breakfast or in the babies before the first feed, and if it is missed, sometimes it is many times missed because it is for the congenital hypothyroidism, permanent congenital hypothyroidism, it is a lifelong treatment. So compliance is very difficult problem, and sometimes it is missed. If it is missed, the next day double dose should be given. And the sugar one tablet of thyroxine is 50 microgram, and it is also in the 100 microgram, but depending upon the requirement, we can use the tablet 50 microgram or 100 microgram. So this slide shows the interactions with thyroxine. So increase the thyroxine dose when there is a reduced absorption, like these are the ferrous sulfate, cholesterol, sucralfate, and the ammonium containing antacids and calcium supplement. These agents, these drugs reduce the absorption of the thyroxine. So in this case, the dose should be increased. These are the other condition in which the dose should be increased is the reduced thyroid hormone production, like the drugs amiodarone, iodine containing drugs, and the lithium. Increase thyroxine dose, increase in case of increased metabolism, like anti-tuberculosis drugs rifampicin, phenobarbital, it is anticonvulsant drugs, carbamazepine is anticonvulsant drug, and warfarin anticoagulant drugs, and the oral hypoglycemic agents. So in these cases, the metabolism is these drugs increase the metabolism, so increase the dose should be increased. Now decrease the thyroxine dose in the following drugs like furosemide, Lasix, mefenamic acid, ponostan, salicylate, dispirine, aspirin, and vitamin C. In these, if the patient is taking these drugs, the dose should be decreased. So post-treatment monitoring is important. In the post-treatment, we usually do the free T4 and TSH, but sometimes we need to do the thyroid binding globulin, and the growth monitoring is very important because the hypothyroidism causes the short stature and delayed growth and development. So on every visit, we have to do the weight, height, and calculate the growth velocity. Follow-up is the recommended follow-up is 2 to 4 weeks after the initial treatment, then if every 1 to 2 months in the first 6 months, then 3 to 4 months between 6 months to 3 year, and then every 6 to 12 months if the patient is stable, and sometimes we need to decrease the dose if there is a if there is side effect. So usually initial dose is high, then we adjust the dose, and if the thyroid functions reports are normal, then we call 6 to 12 months follow up, and 6 to 8 week of any dose change. If we change we are doing the changes, the changing the dose, then 6 to 8 week is period to call for follow up. Overtreatment causes the premature closure of cranial sutures known as craniosynostosis, and there is acceleration of skeletal maturation and behavioral changes. In the children, there is a temper tantrum you have heard about, and there are behavioral irritability, and sometimes some patient get diarrhea. Prognosis depend upon the onset of the treatment. If in the congenital hypothyroidism within 3 months treatment start हो गया है, then the mean IQ, you know the IQ, so will be 89. And if it is delayed for 3 to 6 months and started after 3 to 6 months, then the IQ will be 71. and after 6 months IQ will be 54. So start of treatment is better with high dose, and then adjust the dose, lower the dose when the clinical symptoms are elevated, and the child is growing well, and there is no side effect, and the reports are near normal. Then we will decrease the dose. Poor outcome, very low pre-treatment T4. Number 2, epiphyseal dysgenesis and complete athyrosis. Complete athyrosis means agenesis of thyroid gland. Epiphyseal dysgenesis is appreciated in the newborn period or congenital hypothyroidism. In the epiphyseal femoral epiphysis there is dysgenesis, and previously it was a test for to diagnose the hypothyroidism, but nowadays the other tests are easily available, so it is not in practice, but if there is epiphyseal dysgenesis, there is poor outcome, poor prognosis. Now the take home message is: most common reversible congenital cause of mental retardation is hypothyroidism. Universal screening is ideal. Positive cases should be confirmed by repeating the test in doubt, and T4 and TSH are the prime test. Free T4 and TSH are prime test, and sometimes we need scanning, should not delay. If you are planning for scanning and it will take time, 1 week or 1 month, the treatment should not be delayed. Treatment should be started, and the consultation with pediatric endocrinology should be done, because a pediatrician or a general physician cannot treat the hypothyroidism or in children, because it needs pediatric endocrinology. It needs weight, height, monitoring of growth, monitoring of the thyroid function test. So any these cases should be registered in pediatric endocrinology. Fortunately, pediatric endocrinology services are present in ICH, and the every Wednesday and Saturday we do see the endocrine patients, and on Saturday the thyroid patients are come for follow up. So you can come in the NICH OPD on Saturday and see these features and the treated patients. So in the last is not least, early treatment, excellent recovery. This is the features, clinical features of the hypothyroidism. Uh, Disharmoniousness is a 10 to 15%, and synthetic defect is 10 to 15%. This is the perchlorate discharge test. You can read in your textbook. Thyroid dysgenesis is 85% of permanent, hypo, and maybe sporadic. Primary hypothyroidism includes the dysgenesis and disharmonogenesis, congenital cause. ये छोड़ छोड़